Our final speaker of the day is Dr. Scott Antonia. He completed his medical training and PhD in immunology at the University of Connecticut and his postgraduate training at Yale University School of Medicine. He's professor of oncology, holding the positions of co-leader of the immunology program and recently appointed as the chairman of the Thoracic Oncology Department at the H. Lee Moffitt Cancer Center in Tampa, Florida. Dr. Antonia.
Let me add my thanks here to all of you for coming here, but in particular to Louis and Jerry for inviting me here. I was telling them at dinner last night, I actually grew up in Xenia, and my first job was Dayton Daily News paper route. And then when the hurricane came through in '74, it wiped out our school. So I actually spent some time in school here in Dayton. So it's a real pleasure to come back here now 40 years later. So it hasn't changed much. So. All right, so my topic of discussion is immunotherapy for lung cancer. So clinically, I'm a lung cancer doctor. Scientifically, I'm an immunobiologist. And up until probably 2 years ago, I was always hopeful but very pessimistic that immunotherapy could ever be efficacious for the treatment of lung cancer. And I'm sure all of you in the room were of the same ilk. There was no one who thought that immunotherapy would possibly be clinically efficacious in lung cancer. And that's changed. Shocked us all, to the extent now that there is an immunotherapeutic or a series of immunotherapeutics that will be approved and commercially available that you all will be using in the next 1.5 to 2 years. All lung cancer patients will likely be treated with this, certainly in the salvage setting. Likely it'll work its way into the first-line setting even, and certainly integrated into maintenance therapy. So this is a shock, but a very nice one for us all. So why do we need to develop new therapies? Well, there clearly has been very significant progress over the past 20 years in improving outcomes, refining conventional treatment modalities, getting better screening tests, refining surgical techniques and radiation techniques and chemotherapy. But progress is really leveling off, and in terms of overall survival or reducing cancer deaths, really we're making incremental progress in a lot of cancers. So we need to develop new, novel, non-overlapping treatment modalities, and in aggregate we call those targeted therapies. So this is what I mean by this. These are the data that support those comments. You can see here from 1975 to about 1991, there's this number of cancer deaths in this country on an annual basis. And there's been a steady increase up until this time, and then such that if there wasn't improvements in conventional treatment modalities, this slope would have been the same. But it didn't. It has leveled off, and that has resulted in a reduction of 1 million deaths in this country cancer deaths in this country over the past 20 years. But of course, what we'd all like to see is a negative deflection of this slope. We're not satisfied with this stable situation. So these are the general classes of targeted therapies. They're the signal transduction inhibitors. I heard some of that from Dr. Liao today. The tyrosine kinase inhibitors in lung cancer targeting the ALK and EGFR mutations. There are the gene expression inhibitors, apoptosis inducers, angiogenesis inhibitors, of course, that we use routinely as systemic therapy for lung cancer, monoclonal antibodies, and then what I'll talk about today, immunotherapy. That encompasses what for the longest time was just therapeutic cancer vaccines, but now not necessarily more importantly, but in addition to cancer vaccines, immunomodulatory approaches that have been recognized to be important over the past 5, 6, 7 years. So why should immunotherapy for cancer work? Well, it's an obvious point that cancer cells are genetically unstable. They have multiple mutant proteins. So they should be perceived as foreign by the immune system, right? And we all know that the immune system is incredibly potent and efficient and effective in getting rid of foreign invaders. We don't die from the flu. And so it's extremely powerful. And and it's also been shown that antigenic proteins, these antigens that are specific for tumor cells, expressed by tumor cells but not normal cells of the body, have been shown to exist. They're the so-called cancer testis antigens. Examples are MAGE and New York ESO1. Of course, there are several tumors that are caused by viruses and driven by viral genes. And so in those particular tumors, for instance, Burkitt's lymphoma for Epstein-Barr virus, hepatocellular carcinoma for HPV, and obviously cervical cancer and head and neck cancers for HPV-16. So in those viral proteins could serve as tumor-associated antigens. They're the mutant antigens, as I've already talked about. And then there are a class of antigens that are differentially overexpressed. And we just take advantage of that differential overexpression of proteins, even though those proteins may in fact be expressed in normal cells. And then the final point here that makes this all plausible is that T cells, lymphocytes, cytolytic T lymphocytes that are specific and reactive towards these tumor-associated antigens are clearly present in the peripheral blood, in the tumor microenvironment, and in lymph nodes in cancer patients. So all of the components that are necessary to get rejection of tumors is there, but obviously it doesn't occur in patients who have progressive cancers. And immunotherapeutics that have been developed are relatively inefficacious, actually quite inefficacious. Objective tumor response rates for a good vaccine are 5%. So, and the reason is that same genetic instability that produces these tumor antigens also allow for selective pressure and evolution such that those cells that can evolve to develop ways of evading the immune system survive. So tumors develop ways of evading rejection by the immune system. So that's where we were 6, 7, 8 years ago. We came to the realization that therapeutic vaccines are not all that efficacious. In my opinion, they're still. I think that ultimately for the best efficacy, we need to continue to develop vaccines so that we can increase the number of specific T cells that are circulating, but it's not sufficient. We need to develop strategies that interfere with these ways that tumor cells evade rejection by the immune system. So let me start by talking about a couple of tumor vaccines. We've been developing these for the past 15 years. And these are all the different types of vaccine approaches that have been developed, from simply using tumor antigen proteins or peptides, emulsified and immunologic adjuvants, to putting the gene that codes for these antigens in viral vectors and using those as vaccines. There have been techniques that have been developed that allow us to grow out large numbers of autologous dendritic cells. Dendritic cells are the professional antigen-presenting cell of the immune system, the cells that turn on immune responses, and those can get loaded with tumor antigens. And I'll show you an example of one of those vaccines that we've developed. Others have fused tumor cells to dendritic cells or modified autologous tumor cells with genes of immunologic importance designed to work as immunologic adjuvants. And an approach that others have used, and again, I'll show you an example of one of ours where we do this, and that is to use bystander cells that we stably transduce with genes that we think are important and admix those with tumor cells as the source of tumor antigens. And I want to reiterate the point that though it's easy for a lot of people to get pessimistic about therapeutic tumor vaccines because of the lack of efficacy in the past, this is not the time to abandon them. Sure, alone they will never be effective, but now that we have found that there are these immunomodulatory approaches that greatly enhance efficacy, that efficacy can take a further step up if we can expand the number of T cells that are reactive against these tumors. So there needs to be a renewed or continued effort put into the development of these therapeutic tumor vaccines. So this is one of the two vaccines I'll show you today. This is a vaccine we call GM.CD40L. It's a vaccine specifically for lung adenocarcinoma. It's a gene-modified, cell-based vaccine that consists of 3 different cell lines. So there are 2 lung adenocarcinoma cell lines, and the purpose of this in the vaccine is to produce as the source of tumor antigens. The third cell line is it's just a long-term cell line, K562, an erythroleukemic cell line that we specifically chose because it grows well, as it's transfected easily, and it has no MHC molecules on its surface, so it can't be rejected in an allo response, so we can give it to all patients. And then what we did, so this constitutes the vaccine in this red box. These 3 cell lines admixed together and then injected subcutaneously. The bystander cell line we stably transduced with the GM-CSF gene, forcing it to secrete GM-CSF, and then we also force it to express surface CD40 ligand. GM-CSF can recruit in these dendritic cells into the site. We radiate all of these cells before we give them back to the patients, of course, and those radiated tumor cells then undergo apoptosis, form apoptotic bodies, and that is something that dendritic cells can recognize, engulf, and process. So it can then process the tumor-associated antigens, load them onto surface MHC class 1 molecules. And that complex, the peptide MHC complex, is what the surface antigen binding molecule of a T cell sees, right? Antibody sees nominal protein. T cell receptors, TCRs, see peptide loaded onto MHC molecules. When that binding event occurs, that sends a positive signal to the T cell. But it's insufficient to activate that T cell. T cells require 2 signals to become activated. The second signal is through a second surface molecule called CD28. Now, dendritic cells, immature dendritic cells, are highly capable of processing and presenting antigen, but they're not very good at co-stimulating T cells, so they don't have much of the ligand for CD28 on their surface, immature dendritic cells. So that's the whole purpose of us putting CD40 ligand on these cells. When these dendritic cells work their way into the vaccine site, they'll encounter CD40 ligand. Signaling through CD40 is a potent activation and maturation signal for the dendritic cell. They'll put things like CD80 and CD86 on the surface. That is the ligand for CD28, providing the second signal for T cell activation. Now, T cells need co-stimulation to become activated, but once they're activated, they no longer need co-stimulation for effector function. So they can now migrate out of that vaccine site and go to systemic metastatic deposits and kill tumor cells. The next iteration of the vaccine has been that we put CCL21 in as well. We have CCL21 in a recombinant adenoviral vector. There's no adenoviral receptors on this cell line, so we infect one of these tumor cell lines with this vector that has the CCL21 gene in it. CCL21 is a potent chemokine for both T cells and dendritic cells. So it's just, we hope that this next iteration will be more potent because we'll bring in more dendritic cells and T cells. This is the first vaccine, the GM-CD40 ligand vaccine. We had no objective tumor responses that we could attribute to the vaccine, though quite a few stable disease and perhaps some minor responses. And then we also found that we could induce anti-tumor T-cell responses in about a third of the patients. And if a patient did not develop an immune response, they were unlikely to, more likely to have progressive disease than stable disease. So now we are comparing this in a randomized phase 2 trial that is currently open, this vaccine to the vaccine where we've added the CCL21, and that's well on its way to accruing, and we'll see if that produces a benefit and begin to look at survival advantages, not just the surrogate of tumor response. The next vaccine I wanted to tell you about is once again a gene-modified cell-based vaccine. But here, in this case, we're using dendritic cells, autologous dendritic cells as the cell. And the tumor antigen that we're targeting with this is P53. So, when people first hear that, they say, well, that doesn't make any sense. P53 protein is expressed on all normal cells, right? So we're going to be getting lots of autoimmunity. So what's the idea here? Well, the idea is that wild-type P53 has a very short half-life. And very little P53 protein is expressed in a normal cell. You don't need much P53 to put the brakes on proliferation. And in fact, if you stain a normal cell for P53 immunohistochemically, you can't see the proteins. That's shown here. So this is nests of adenocarcinoma cells that we know have a mutation in the P53 gene invading into this normal stroma that has very little P53. When there's a mutation in the P53 gene, of course, it knocks out its tumor suppressor functions. But another consequence of that mutation is, for whatever reason, mutant P53 protein is very stable and therefore massively overexpressed. So we're just taking advantage of this differential overexpression of P53 in mutant P53 containing tumors. And it turns out that in small cell lung cancer, 90% of them have mutations in the P53 gene, hence the selection of that disease for us to study this vaccine in the first time that we tested it. We manufacture these vaccines, as is shown on this slide. We leukapheresis patients to get peripheral blood cells. There are not very many dendritic cells in the peripheral blood, but there's lots of dendritic cell precursors. And so what we do is we culture the adherent precursors in the presence of GM-CSF and IL-4 for 5 days. That's enough to drive precursors to immature dendritic cells. And then we load them by infecting them ex vivo with a recombinant adenovirus that has the human P53 gene in it. And we use that for two purposes. The first, of course, is this is a vaccine preparation. We've stained with a cocktail of antibodies that are specific for all lineages other than myeloid cells. And the HLA-DR, class 2 positive lineage negative cells are dendritic cells. So half of the cells that come out of these cultures are dendritic cells, and a third of them express large amounts of intracellular P53. The second consequence of adenoviral infection of a dendritic cell is it forces maturation. So as I said before, immature dendritic cells don't have much CD8 or CD86 on their surface, but when they are infected, that drives them to become mature and able to co-stimulate T cells. So that's the vaccine. We gave it in the phase 1/2 study. We gave it to patients who had previously been treated with chemotherapy and had relapsed disease. And we were able to nicely show that half of the patients developed P53 specific T cell responses. So we sample the blood of the patients before vaccines. Here are the vaccines, every other week times 3, and then once a month times 3. And we stimulate the peripheral blood with nothing, an irrelevant peptide or a P53 peptide, and do these assays called ELISpot assays. It's just a way of allowing us to count the number of gamma interferon secreting T cells in this assay. And you can see that there was a very nice and antigen-specific, P53-specific T-cell response that was induced by the vaccines. We learned, as lots of other people have learned, that this response can wane over time, emphasizing the need for all of us who do therapeutic vaccines to plan on a booster schedule after the priming phase. In this study, we were able to see some tumor responses that were directly produced by the vaccine, directly attributable to the vaccine. This is a patient who initially had a limited stage disease, had radiation to the chest, did not recur in the chest, but recurred in the retroperitoneum, biopsy-proven enlarging PET-positive retroperitoneal lymph nodes that you can see nicely shrink after getting the vaccines. And we had 3 of these. So we had 3 of the 50 patients who had objective tumor responses. So that's very good, obviously proving the biology that this approach can be useful. The immune system can be harnessed to kill cancers in some patients, but we're up against that same glass ceiling that everyone else is up against, and that's just a 5% or a low objective tumor response rate. But there's another interesting observation. So being a translational scientist and continuing to treat these patients in addition to working in the laboratory, as I continue to treat these patients, we make observations that we then bring back into the laboratory. And here's one very important one. As I continued to treat these patients with salvage chemotherapy, when they progressed after we gave them the vaccine, they seemed to be responding to chemotherapy much more frequently than we're used to. And that's easiest to see in the platinum-resistant patients. So the medical oncologists in the room know that platinum-resistant patients are those patients that progress within 90 days of the last dose of platinum. It's a particularly poor prognostic group. No matter what you give them as salvage therapy, they respond less than 5% of the time. In our study, there were 21 platinum-resistant patients who got salvage chemotherapy after a vaccine, and they responded 48% of the time. So again, lots of caveats here, unplanned subset analysis, but the difference between 5% and 50% there's quite a splay there, so we're hoping that is going to stand up. This also seemed to correlate with immune responsiveness. So if a patient was a P53 immune responder, then there was a 75% chance that they were likely to be a clinical responder to salvage chemotherapy, in contrast to those P53 non-responders, so immune non-responders were unlikely to respond to salvage chemotherapy. And the other interesting thing is this tail of the curve, which is the promise in the signal that we're getting for a lot of different immunotherapies. That really is what drives so much interest in immunotherapies. You all know that your patients don't want their median survival to be shifted by a month. No, they want to be here. They want to be a long-term survivor. And so this is the promise of immunotherapy. So, and we're seeing this with 4 patients being alive greater than 4 years after receiving the vaccine. Obviously, again, lots of caveats. Highly selected patient population, phase 2 study needs to be confirmed. All we really know is that P53 is a viable antigenic target for immunotherapy for cancer. There is no significant toxicity. We can get P53-specific immune responses in half of the patients, and there is some clinical activity with a 5% response rate. And we are now testing this hypothesis-generating observation that chemotherapy given after immunotherapy can be synergistic. And we're doing that in a randomized phase 2 trial that has 3 arms. We're taking patients who are newly diagnosed. They all get standard of care chemotherapy, 4 to 6 cycles of platinum and etoposide. And arm A is the observation arm. They get no vaccines. They get what all patients off study get, and that's observation until progression. Arm B, the patients are getting the P53 vaccine. And in arm C, they're getting vaccine plus all trans-retinoic acid. And I'll explain in a few minutes why patients are getting ATRA in that arm. And then, of course, at the time of progression, everybody gets single-agent paclitaxel, so we'll be able to formally address this hypothesis in prospective fashion. So what is the mechanism of this? So we bring this observation back into the laboratory and try to dissect why it is, so that if we can understand further how it works, then that will inform our next iteration of vaccine or immunotherapeutic approach and clinical trial. So it's this true bench to bedside, back to the bench and bedside again, translational research circuit. So we took small cell lung cancer cells and we treated them with nothing, or chemotherapy alone, or a form of immunotherapy, soluble trail. Trail binds to a death receptor that is one of the ways that cytolytic T lymphocytes kill their targets. Or they got both. And you can see here that there was the induction of BCL-XL expression, an anti-apoptotic protein. And there was some induction with the immunotherapy, but when we combined the two of them, the immunotherapy abrogated the upregulation of the BCL-XL, which obviously could be one of the mechanisms whereby these tumor cells, in fact, develop resistance to paclitaxel by upregulating BCL-XL. Also found that phospho-BAD was decreased, and uniquely apoptosis-inducing factor, this caspase-independent apoptosis pathway inducing protein, was specifically induced. So what do we think is going on here? So unphosphorylated BAD binds BCL-XL, inactivating it so that it cannot inhibit or suppress apoptosis, be that caspase-dependent or caspase-independent pathways. We're seeing with chemotherapy treatment, there is phosphorylation of BAD, and so that it can no longer bind to and inactivate BCL-XL. BCL-XL can then suppress these apoptosis pathways. So we think that the combination of the two enhances apoptosis in ways that couldn't happen with either one alone. A second mechanism of synergies that was worked out between my lab and Dmitry Gabrilovich's lab. Dmitry is a scientist who is at the Moffitt Cancer Center. And what we've discovered was that, so let's go back to how T cells kill. So a T cell, of course, senses antigen on MHC through its T cell receptor. Once that binding occurs, there is what is called an immunologic synapse that forms between the two cells. And within that synapse, the T cell secretes perforin. Perforin just is proteins that poke holes in the membrane. And they also secrete granzyme B. Granzyme B is a catalytic protein, and so it can get in through these pores, and it can then chop up proteins that leads to apoptosis in the target cell. Normally, tumor cells do not express this protein, this receptor called the mannose-6-phosphate receptor. But he found primarily that when a tumor cell is stimulated or is treated with chemotherapy, there is the induced expression of this mannose-6-phosphate receptor. And it turns out one of the things that this receptor can do is bind and internalize granzyme in a perforin-independent fashion. So you can see that normally a T cell can kill this one cell at a time. But when tumor cells are treated with chemotherapy, can kill cells 360 degrees spherically all around the T cell. And we think that leads to this synergy. So this again is another paradigm shift. A decade ago, everyone would say, well, it's silly to combine chemotherapy with immunotherapy. Chemotherapy is immunosuppressive. You're going to be quelling your efficacy that you're trying to induce with the immunotherapy. But it's just, if you use it right and you understand the basic biology, then it actually could be used to our advantage. We aren't doing this, but there are people now over the past 5 or 6 years clearly showing that chemotherapy can be given to influence the afferent limb of the immune system. That is the priming part of the immune response. And that is therefore, of course, to give chemotherapy before vaccine. It's been nicely shown that if you use lymphotoxic chemotherapy like Cytoxan or fludarabine, and you induce a lymphopenia, well, one of the things that happens in the immune system is there is a reactive, what is called a homeostatic T cell proliferation. And if you immunize during that period, the cytokine milieu is such that the immune response is much better. Also, you can use lymphotoxic chemotherapy to deplete suppressor cells of the immune system. Suppressor cells, T cells of the immune system that suppress immune responses are called regulatory T cells, or Tregs. So you can use chemotherapy to deplete those. These are often overrepresented in cancer patients and certainly are present within the tumor microenvironment. Chemotherapy may also accomplish debulking in chemotherapy-sensitive disease, perhaps reducing the immunosuppressed milieu of the patient. And this is the very interesting thing that has been discovered by other groups, is that T-cell death leads to antigen release in a fashion that allows it to be taken up by antigen-presenting cells and cross-presented to other T cells. So chemotherapy, and in fact, radiation therapy can be immunotherapy. Our work is showing that we can use chemotherapy to influence the efferent limb. And we talked about this already. Other people now have since shown that there can be increased T-cell access to the tumor parenchyma. There can be increased antigen expression. There can be increased expression of death receptors. And then I mentioned the two mechanisms that we have worked out. Okay, so what can we say about tumor vaccines? They can frequently expand tumor antigen-specific T cells, so vaccine technology is such that it can accomplish that, which I think is a very significant accomplishment that we can exploit in the future. It doesn't produce much clinical efficacy by themselves, and so we need to develop this combination immunotherapy to target these mechanisms that tumors use to thwart immune responses. So what are those? There are a variety of different agents that are being looked at by a variety of different groups, and we're looking at several of these. The various classes are shown here. They're agents that can modulate immune responses, and they can be the T-cell growth factors. You know, of course, you can use interleukin-2, which is T-cell growth factor, but there are others, like IL-21, that can preferentially expand CD8 cells, and we're running a clinical trial in collaboration with BMS right now with IL-21. There's IL-15. There's IL-7. There are the anti-checkpoint agents, and we'll talk about those in a lot of detail in just a couple of minutes. These are the most exciting immunomodulatory agents in terms of clinical efficacy right now, and other co-stimulatory agents. Another class of agents are those that can eliminate suppressor cells. So within the tumor microenvironment, there's immunosuppression. So no matter how many T cells that you induce and expand with vaccines, when they wander into the tumor parenchyma, the microenvironment of the tumor, they are shut down. And they're shut down in a variety of different ways. One is to aberrantly express checkpoints, and we'll talk about that in a minute. But there's also the recruitment of a variety of different suppressor cells. We talked about the regulatory T cells, but there are also MDSCs, myeloid-derived suppressor cells, that are operational in suppressing immune responses. There are TAMs, tumor-associated macrophages. And it turns out, Doug Fearon nicely showed in a paper now a couple of years ago that actually cancer-associated fibroblasts, or CAFs, have the capability of suppressing immune responses within tumors as well. Also present within the tumor microenvironment are cytokines that are secreted that are immunosuppressive. There's interleukin-10 and TGF-beta. Both of those are immunosuppressive cytokines. There is an excess of adenosine, and adenosine binds to adenosine receptors on T cells and shuts them down. And we'll talk in a lot more detail about that in a minute. And IDO can be co-opted. IDO is indolamine 2,3-dioxygenase. An immunosuppressive enzyme can be co-opted by tumors to derive suppression. And then we already talked about chemotherapy. So one of the co-stimulatory molecules is being developed. This one is being developed by Pfizer. It is an antibody, a monoclonal antibody, and it does what I told you we were doing with our GM-CD40 ligand vaccine. We're doing it with CD40 ligand protein that we expresses a transgene in the bystander cells. Well, they've developed an antibody that binds to CD40 and mimics CD40 ligand. So it's an agonistic or activating anti-CD40 monoclonal antibody. And Bob von der Heijden and I did the first-in-man study with that antibody several years ago, and there was some promising clinical responses, and Bob has now made some major observations in pancreatic cancer with this, and that's being pursued further by his group and the cooperative group that is doing immunotherapy clinical trials in this country now. We've spent quite a lot of time thinking about myeloid-derived suppressor cells and how, principally because Dmitry Gabrilovich is an international expert on this and was at the Cancer Center just until recently. And so we collaborated with him to look at ways of influencing this immunosuppressive mechanism. These are immature myeloid cells. This is what they look like in terms of their surface phenotype. And he and many others have through the years shown that there are a huge number of these present in the peripheral blood, in lymph nodes, and in the tumor parenchyma in cancer patients. And he reasoned that this drug, of course, that you all, the hematologists in the group know they use to treat promyelocytic leukemia, acute promyelocytic leukemia. It's a drug that's available commercially. So because it can force the differentiation of these malignant myeloid cells, he reasoned that it may also force the differentiation of these, and produced a lot of preclinical data in support of that. And so that was why we are now including that in that arm C of that 3-arm trial I told you about, with our P53 vaccine in combination with Atra to treat patients who have small cell lung cancer. So that trial is ongoing, but we took a peek at the early data that came out of this, and Dmitry did much of this work, and we published that recently. But we nicely showed that there are this number of myeloid suppressor cells in the patients in arm A, this number in arm B before treatment, no influence with the vaccine. But in arm C, there was this nice reduction in myeloid-derived suppressor cells in the peripheral blood without negatively impacting the good cells, the dendritic cells. And this is early, but it also appears that when driving down those myeloid-derived suppressor cells, we're also improving the anti-P53 T cell response. So let's shift to adenosine, another molecule that we're very interested in bringing into the clinic. So why adenosine? Adenosine is present in the extracellular tumor microenvironment in high concentrations. And that's due to the Warburg effect. The Warburg effect, of course, is that there's this differential, preferential utilization of the glycolytic pathway for energy metabolism, right? So, and that's a relatively inefficient way of producing ATP, so there's an excess of AMP. And then AMP builds up in the tumor microenvironment. It turns out that tumor cells and cancer-associated fibroblasts express this surface ectonucleotidase called CD73. That degrades AMP to release adenosine. So there's a ton of adenosine present in the tumor microenvironment. And adenosine is a signaling molecule. So it has receptors. And it has receptors in the brain. It's the A2A receptor binding to adenosine is felt to be responsible for progression in Parkinson's disease, for example. Well, on T cells, the A2A receptor on T cells, when it signals, it shuts down T cell function. So here we get a bunch of T cells and we stimulate them and increasing concentrations of an A2A receptor that doesn't get degraded by adenosine deaminase is called CGS. And you can see that with increasing concentrations there is reduced T cell proliferation and reduced cytokine release that is rescued with this A2A receptor antagonist. Now we stained a bunch of tumors for A2A receptor, lung tumors, about 65 of them. looking to see if there were T cells that expressed A2A receptors, and found that there's actually a fair number of these tumors that the tumor cells themselves express the receptor, and also in some of them the cancer-associated fibroblasts express the A2A receptor. So that led us to think, is there a phenotype? If they're expressing these receptors, are they doing something that is beneficial to the tumor and, of course, detrimental to the patient? So we grew out a bunch of cancer-associated fibroblast cell lines. And these we grow these out. They're very pure. They express alpha SMA, that's a fibroblast marker, and they all express FAP, a highly specific marker for cancer-associated fibroblasts. They also all express that ectonucleotidase CD73. So when they're sitting there in culture, they're making excess AMP, and they're generating their own adenosine, so it's really an autocrine growth factor loop. And we found, though, that when we put in this A2A receptor antagonist, we could inhibit the growth of these cancer-associated fibroblast cell lines through the induction of death. And we also interestingly showed that there was a similar effect in tumor cells. So adenosine supports the growth of cancer-associated fibroblasts, but they also support the growth of tumor cells. So this is PC9, a lung adenocarcinoma cell line, and these are what they look like under control conditions versus after we add in the A2A receptor antagonist. There's induction of cell death, and that is rescued by, it's caspase dependent. So the tumor cells that are treated with this A2A receptor antagonist have an accumulation of cleaved PARP that is inhibited by this caspase inhibitor, ZVAD. So we think that, we want to use these A2A receptor antagonists because we think that they'll have have pleiotropic beneficial effects for the patient. We know that if we can block this, so adenosine binding to its receptor inhibits T cells. So if this can be blocked, T cells could function better. We know that cancer-associated fibroblasts produce their own independent inhibition of T cells. So if we can block this positive effect of adenosine on cancer-associated fibroblasts, we can then consequently reduce the immunosuppression. And then we also think that there could be a direct effect on the tumor cells themselves. So there are several companies that are developing adenosine A2A receptor antagonists for the treatment of Parkinson's disease. And they, as you all know, in drug development, drug companies don't give us doctors who have patients who die of cancer on clinical trials when they're testing drugs in patient populations where patients don't die. Otherwise, they're always stuck with having to try to sort out, was it a cancer-related death versus a toxic death from their drug. So they're not giving it to us now. But they're in randomized phase 3 registration trials now, and they're pretty far along in their accrual. So these will likely become available to us within the next year or two. And the minute they are, we're going to integrate these into clinical immunotherapeutic clinical trials. I mentioned IDO before. We were the first group to demonstrate that this mechanism could be co-opted by tumors to evade rejection. IDO is indolamine 2,3-dioxygenase. It degrades tryptophan along the kynurenine pathway, and it's David Munn and Andy Meller at the Medical College of Georgia showed now well over 15 years ago that this is one of the ways that the placenta prevents the allorejection of the fetus, right? The maternal immune system should reject the fetus that has paternal alloantigens, but the placenta makes this enzyme IDO that is at least partially responsible for preventing that allorejection. It also normally functions to control autoimmune disease and that's been shown in a variety of different experimental conditions. And about a decade ago, we showed that IDO could actually be co-opted by tumor cells as one of the ways that they evade rejection. So we took that through the RAID program at the NCI at the time, and then it got shifted over to the drug development group. They did the farm tox studies and formulation for us. It's actually now a CTEP agent that's in their portfolio. We've completed the phase 1 trial and now doing it in combination with our P53 vaccine actually this is not in lung cancer, it's in P53 overexpressing triple-negative breast cancer. And we're also combining it in a phase 2 trial now with docetaxel as well. We don't think that D1-methyltryptophan is inhibiting the enzyme. We don't think it inhibits IDO1, but it does clearly inhibits this pathway. And we think that one of the ways that it is doing it is by enhancing CD80 and CD86 expression and diminishing PD-L1 expression on dendritic cells. CD80 and CD86 are the co-stimulatory molecules. PD-L1 is the inhibitory molecule on a dendritic cell. So you can see if we make dendritic cells, and this is what they look like without stimulation. If we stimulate them with LPS and gamma interferon, they begin to put more CD80 and CD86 on the surface, but they also put PD-L1 on the surface. So this is a naturally occurring mechanism, right? Whenever we turn on an immune response, we always have to get the wheels in motion to eventually turn it off, right? When we get infected by influenza, we want to clear the virus, and then we want to shut it down, or otherwise we'd just be a big bag of inflammation for all of the antigenic insults that we suffer throughout our lives. One of the ways that the immune system naturally does that is that after it stimulates the immune response in delayed fashion, there is inhibitory molecules that get induced to be expressed on the T cells and the dendritic cells, so that it can then subsequently shut it down. Well, when we treat the dendritic cells with LPS and gamma interferon in the presence of 1-methyltryptophan, there is a further enhanced expression of CD80 and CD86. And by the way, this is an extremely potent combination to stimulate dendritic cells. So that's even better, and then the PD-L1 expression, the negative molecule, is not induced to as great an extent. PD-L1 does a variety of things. It binds to PD-1 on T cells to shut them down, but it also supports the generation of regulatory T cells. And in the patients that we're treating on the clinical trial, we're seeing this, that the dendritic cells in the peripheral blood of patients that are on 1-methyltryptophan have less PD-L1 on the surface and fewer CD25, FOXP3 positive regulatory T cells in their peripheral blood. Okay, so this brings me to the final thing that I'm going to talk about, and these are the immune checkpoint inhibitors. The medical oncologists in the room know of at least one of these, because there is a commercially available antibody that blocks CTLA-4. It's called ipilimumab or Yervoy, and it's standard of care treatment for the patients with metastatic melanoma, one of those dramatic developments in the treatment of melanoma for the past 5 years. So let's go through this schematic here. This cell up here is a tumor cell or a dendritic cell. This cell down here is the T cell. Again, T cells have T cell receptors. They bind MHC class 1 or class 2 molecules, and that sends signal 1 to that T cell. And then there's not a CD28 molecule on here, but B71 and B72 are also called CD80 and CD86. Those are the things that bind to that CD28 to give signal to. These molecules are co-inhibitory molecules. These molecules that the T cell is induced to express later on to shut itself down later on. One of them is CTLA-4. This is an alternative ligand for CD80 and CD86 and can outcompete CD28. And the consequence, though, of this binding event is inhibition. So antibodies have been developed, antagonistic antibodies have been developed that block that interaction. I'll talk about that in a minute. Another one is PD-1. I told you about that. PD-L1 binds to PD-1 on the T cell and shuts it down. And there are antibodies that are being tested in the clinic right now with that, and you will be prescribing these for your patients within the next year and a half to 2 years. And then there are a variety of others that are just being targeted right now that there are no clinical data for. They're LAG3, TIM3, BTLA4, etc. So anti-CTLA-4, there are 2 companies that have developed blocking antibodies that bind to this CTLA-4 preventing this interaction from occurring but allowing this interaction to continue to occur, so you get stimulation without inhibition. The BMS compound is ipilimumab, Yervoy. And there's another one called tremelimumab, which is being developed by MedImmune. It was initially developed by Pfizer and now taken over by MedImmune. Neither of these have been tested as single agents in lung cancer. There was a paper published about 2 years ago by Lynch combining ipilimumab with chemotherapy, and there was a signal there that this may be beneficial. And we're running trials both with the MedImmune compound as well as the BMS compound in combination with blocking antibodies for PD-1 and PD-L1. And those data haven't been presented anywhere yet, so I'll not be talking about that today. We've done a lot of work with antibodies that block PD-L1 and PD-1. Again, that's this interaction here. This is dendritic cells that we didn't isolate, but we stained, that came out of a disaggregated lung cancer, and the dendritic cells express high levels of PD-L1, but also cancer-associated fibroblasts and tumor cells can express it. This is a molecule that can be induced by gamma interferon stimulation. So the tumor microenvironment is an inflammatory microenvironment, and that inflammatory microenvironment is immunosuppressive. One of the ways is that one of these inflammatory cytokines, interferon gamma, can induce the expression of PD-L1. So a variety of different companies are developing these, and we're working with all of them. Merck, BMS, and CureTech all have anti-PD-1 antibodies. Genentech and MedImmune have anti-PD-L1 antibodies that they're developing, and we're participating in all those trials. But the furthest along and the one that we've done the most work with is anti-PD-1 from BMS that is now being called nivolumab. So this is the first trial that was done. It was a dose escalation trial, and they looked at a variety of different cancers, and this is where we first became shocked that immunotherapy can work for this disease. But you can see that it has very nice activity in the what we think of as the conventionally as the immunotherapeutically responsive diseases, melanoma and renal cell carcinoma. Nice response rates, better than you see with ipilimumab, right? Ipilimumab, you see response rates of, I don't treat much any melanoma, but I think it's like 5 or 10% response rates. And they're seeing upwards of 30-40% response rates with single-agent anti-PD-1 in melanoma. Nice 24 to 31% response rates for renal cell. But here's the real shocker, in that lung cancer was responsive. Depending on the dose level, 18 to 32% of the patients were responding in this study. This is one of the patients that we treated at Moffitt, and I show this to illustrate two things. One is that it's clinically efficacious, but there's this other thing that y'all have to learn to adapt to, and I know many of you treat melanoma already have done this for Yervoy, because there's this recognition that tumors can actually get bigger in size before they shrink. And so if patients are kind of doing okay, then with that first CAT scan that you get, even if it shows progression and they have no symptoms that make you think that there's progression of disease, then patients should stay on, because they could later, in delayed fashion, respond. So this is a patient with lung adenocarcinoma, and she had an EGFR mutation and failed 3 lines of chemotherapy and targeted agents or lotinib, and she had these bilateral multiple pulmonary nodules, just showing a couple here. And then after 2 months of nivolumab, these things were actually bigger. So if this was a chemotherapy trial, we'd say progression, time to come off. But because it was immunotherapy and we recognized that this was a possibility, it was built into the protocol that patients could stay on in the face of progression. She felt great, by the way. She felt better than she had before she started the treatment. And so at 4 months, you can see there's the near disappearance of these tumors. And this is not an uncommon thing, and which is what has us all very enthusiastic about this drug. We've now gone on to expand the cohorts with that initial signal, conducted a trial, and have completed accrual to cohorts. We're looking at 3 different dose levels, but putting many more patients on each of these dose levels. So a total of 129 patients were treated at these 3 dose levels. And you can see that it was holding up. First of all, probably 1 mg per kg won't be useful. So so if you take that out and you just look at these the 3 and 10 mg per kg cohorts, there's a 20 to 25% objective tumor response rate. And there's also a whole bunch of stable disease as well. So these are. This color is 1 mg per kg, that's 3 mg per kg, and that's 10 mg per kg. The reason why they divided up squames versus non-squames is because in the initial studies there was some signal that squames could be much more sensitive to this than the non-squames. It turns out it's not the case. As we put more patients on, it's probably just as efficacious in each of those histologies. But you can see that there are a large number of even fairly deep responses, but also a large number of stable disease as well. But this is what I think is the reason to truly become excited about this, not only in lung cancer, but also even more so in melanoma, even more so in melanoma when they're combining anti-CTLA-4 with anti-PD-1, where they're seeing these brisk, deep, durable, near complete responses. But this is going back to just single agent, because these are the data that I can show you today. Single agent nivolumab, these are the 3 mg per kg patients. And there's these patterns of responses where there can be an increase and then a subsequent decrease. That can happen, so you need to be aware of it. It's not a very frequent event, though, with anti-PD-1. And that's why, because we don't think that we're expanding anti-tumor T cells. I think what we're doing is within the tumor microenvironment, and when the T cells wander in there, they're no longer shut down by being the brakes being put on them through PD-1. So there's probably preformed tumor reactive T cells that are allowed to work. So there's a fairly rapid response in most of the patients, but this is the interesting thing, that there is this prolonged response, that there are these durable responses. And obviously if something is durable enough, then you can even start to think about long-term survival. It's also interesting that once you stop treatment, the responses can persist. So in this trial, patients were given drug up to 2 years, and then it was stopped. It was just an arbitrary thing. So these are patients that have gone out that long, and they remain in response this amount of time after stopping the nivolumab. Other patients have had to stop earlier on for toxicity, but if they were responders, they continued to respond after they were stopped for toxicity. And again, this is what we're interested in, this tail of the survival curve. Again, these are heavily pretreated patients, and the 1-year overall survival is 42%, and then there's maybe upwards of 15% of patients who might be long-term survivors. Obviously, just a preliminary look at this phase 2 data that needs to be proven in later phase trials. It's a safe drug to give, and the majority of the patients actually have few to no symptoms. They feel fine on this thing. But there's a new set of toxicities that you have to learn about. So it's something different than the set of toxicities that we normally deal with, chemotherapy-related toxicities. The most common side effects are fatigue, loss of appetite, and diarrhea. But these are the things that require special attention, these select AEs or immune IRAEs, immune-related adverse events, autoimmunity. And this is the most surprising and dangerous one, pneumonitis. So this was unexpected. And so we were caught off guard by it, hadn't yet learned to recognize it early and not yet learned how to treat it, and so there were some deaths that were a direct cause of pneumonitis. So it can be lethal. There can be DAD, diffuse alveolar damage, and ARDS, and death. And so it needs to be recognized. But now that we have algorithms in place, we know to look for increasing cough, a little bit more hypoxia, a little bit more dyspnea. We're very quick to get CT scans, and we bronch everybody who has some infiltrate that could be suggestive of pneumonitis. And then they get treated. And treatment has to be high-dose steroids. So if somebody is even a bit hypoxemic from their baseline, I bring them in and I give them a gram of Solumedrol a day. And I give them that every day until the hypoxemia begins to reverse. And then they still get very high-dose steroids, things that were, obviously, we as medical oncologists never think of, that they're massive doses, 240 milligrams of prednisone a day, and just drop it in 20 milligram increments over 4 days and taper them over 6 weeks. So they need PCP prophylaxis with Bactrim, and sometimes we even have to bring in infliximab. And if we do bring in infliximab, because they're refractory to the steroids, then I would also strongly recommend that you use aspergillus prophylaxis with voriconazole as well. The other immune-related adverse events that we see are rashes, some diarrhea, though not as much as you see with ipilimumab, with Yervoy, pulmonary endocrinopathies, though you all know that with ipilimumab you can see hypophysitis and panhypopit. We're not seeing a lot of that with anti-PD-1, but we see fairly commonly thyroiditis and hyperthyroidism, followed by a burning out of the thyroid and hypothyroidism. But again, nothing to worry about because we have thyroid hormone that can be given as a pill. We see hepatitis, autoimmune hepatitis. Usually it's not medically significant. It's a numeric value, though we never let it get to the point where there is hyperbilirubinemia before we stop drug and treat with steroids. Infusion reactions, I've seen some chest tightness, shortness of breath, hypoxia, stuff that you see with monoclonal antibody infusion reactions. And also nephritis, autoimmune nephritis with eosinophils in the urine and elevation in creatinine. Again, stop drug, put on steroids. All right, so what can we say about anti-PD-1 in lung cancer? It can produce durable responses. There's an encouraging survival profile. We can give it in the outpatient setting with manageable safety. Probably 3 and 10 mg per kg cohorts are better than 1, and most of the trials going forward are at 3. And in some patients, tumor responses continue after you stop therapy. So what we're also now doing, again, this is kind of the same group of us that are doing all of these studies. They are Memorial Sloan Kettering, Yale, and Hopkins. And now we're looking at new combinations. So in these cohorts of this clinical trial, we're moving it into the first-line setting in combination with chemotherapy. So we've completed accrual to this. So we gave nivolumab in combination with gem and cisplatin for the squames, PEM-cis for the non-squames, paclitaxel carboplatin for any histology, either with 10 or 5 mg per kg of the nivolumab. So we don't have the survival data on this yet, but it's looking promising. So here are the objective tumor response rates in parentheses for each of these arms. So there's a 33, but 47, and 50% tumor response rates. And this is what I think is even more telling in that there were no progressors. So there were no progressors in patients who were treated with any of these. There was stable disease or better in all of the patients. So we'll have to see what the overall survival data show us. Similar, the toxicities occurred in 95% of patients, but the vast majority of these were the typical adverse events that we see that are attributable to chemotherapy. Grade 3/4 AEs were in 45% of the patients. There were still some pneumonitis patients. Again, this is what we see, about 5 to 10% of patients develop pneumonitis. fatigue, some renal failure. No deaths attributed to the study treatment, so not really seeing deaths from pneumonitis anymore now that we know how to manage it. There were no DLTs at the higher dose, 10 mg per kg. The immune-related AEs were manageable, and they occurred they occurred to the extent where the nivolumab had to be stopped in 21% of the patients. So there's encouraging overall response as the surrogate for clinical efficacy in chemotherapy-naive patients. We don't know the survival data yet, and obviously we need to do randomized clinical trials. So this is what we're doing next, or we're nearly completed accrual to most of these cohorts. We're looking at nivolumab monotherapy in chemotherapy-naive patients. Again, the objective tumor response rate of these drugs in the refractory setting is 24%. And so moving into the first-line setting is reasonable. We're combining it with anti-CTLA-4 ipilimumab in chemotherapy-naive patients at a couple of different dose and schedules. We're combining it with erlotinib in treatment-naive and erlotinib refractory patients in patients who have EGFR mutations. Combining it with bevacizumab in the maintenance setting or as a single agent in the maintenance setting after first-line chemotherapy, and also treating patients who have untreated asymptomatic brain metastases to see what it does to brain metastases. So that's it. Just to wrap things up in this last slide, I'll reiterate the point that I think that we need to continue to develop vaccines, and we now have written 2 clinical trials to combine vaccines with with anti-PD-1 and anti-PD-L1. We need to continue to discover the mechanisms whereby tumors evade rejection, right? When you give anti-PD-1, you only help a quarter of patients. Well, so maybe there are these driver immunosuppressive mechanisms, and we need to discover what the others are. So there still needs to be basic research done to discover these, and then to develop strategies to thwart those evasive mechanisms and use combination immunotherapy. Need to be vigilant for unique toxicities that pop up. This is a new class of therapeutics, and we're seeing new things develop. And this is the most important point, is that there's real hope in my mind for the first time in the 20 years I've been treating lung cancer patients that we may, and I've come from 22 years ago when I trained, where there was so much nihilism that it was okay not even to offer chemotherapy to patients at all. And then it evolved to, then we can give chemotherapy and maybe we're helping people a bit, and then obviously with maintenance therapy. But nobody's ever really thought about long-term survival in this disease, and I think we're going to see it. So these are the folks who did the experiments that I described along the way. And with that, happy to take any questions. Everybody's tired.
Okay. One of the questions I have is, do you have a preferred time frame for re-imaging after you give immunotherapy? You showed it the 2 months and the 4 months. Is there a magic number around 3 months, or is it different for everyone?
No, stay with 2, because there's going to be, as you know, with lung cancer, there's going to be a fair number of patients who have fairly rapid progression and are clinically progressing. So stick with 2, just like you do with chemotherapy, and just assess the patient. The patient says, I'm feeling fine. Actually, I feel better than I did than when I started this. And then there's radiographic progression, you keep them on. If they're saying, I feel lousy, and the tumors are growing, then you take them off. So no, I really am always reluctant to wait any longer than 2 months to re-image the patients who have systemic disease. Okay, thank you very much.